Okay, so looking at the endocrine system, it's important, I think, that we talk about the endocrine system early in the semester because we're going to go through the different body systems, and a lot of them have hormones that they're either responding to or producing in that system. So we're going to kind of just do a quick overview here of the endocrine system. When you look at what's unique about the endocrine system, it's a series of organs scattered throughout the body. Here's all the endocrine glands. There's only one that's not made of actual endocrine tissue, glandular tissue. And if you look at the list, what organ there do you see listed that is not endocrine tissue, but it's part of another system? You probably studied it in general A&P. Because when we look at them in the cadaver, all these glands, they have kind of a cottage cheese appearance to them, the truly glandular structures. But there's one in here that's made up of a completely different type of tissue. Yes? What? Pineal is a true endocrine gland, so that is still glandular tissue. It's part of the brain. The brain is made up of what type of tissue? Remember from general A&P, what's the tissue that makes up the brain and nerves? Nervous tissue. Which one of those is a nervous organ? Yeah, the hypothalamus. So the hypothalamus, even though it's included in the endocrine system, it's not an endocrine gland per se. It produces hormones, it does. It's important for endocrine function. It's controlling the endocrine system. It also controls what other major system, which is parasympathetic and sympathetic response. Remember what system that is? Yeah, the autonomic nervous system. So it's an endocrine gland in the sense that it produces hormones to the blood, but it's not made of like endocrine tissue. It's made of nervous tissue. So it has a dual role. It's part of the nervous system, controlling the autonomic nervous system. It controls our, our thirst, our hunger, our body temperature. Hugely important organ, pretty insignificant if you remember when you looked at it in the sheep brain, just that little tiny space below the thalamus before you got to the pituitary gland. So hypothalamus controls endocrine secretion. It's boss over the endocrine system. And the rest of the glands produce their own hormones, and some have local effects also of secretions they make. Like if we look at the pancreas, for example, the pancreas not only secretes the hormones insulin and glucagon to the blood, it also secretes digestive enzymes locally to the duodenum via ducts. So some of these organs have dual functions. They're endocrine gland, and they're also called an exocrine gland, which means they secrete chemicals locally, not into the blood. So when we look at the endocrine system and some of its key characteristics, it secretes hormones transported in the blood. So hormones and blood are two defining characters of an endocrine gland and the endocrine system. So any organ that secretes a hormone to the blood is an endocrine gland. And the endocrine system works with the nervous system to maintain homeostasis. So when you look at just generalized homeostasis, balance and just that negative feedback we see for blood pressure control, blood sugar control, heart rate, all the different variables affecting homeostasis. It's the autonomic nervous system and the endocrine system working together to keep things at an even keel. So the nervous system is faster acting, so we need quick response to blood pressure. Say when you're laying down and then you stand up to let the dog out or to go get a snack and you feel a little dizzy, well, the autonomic nervous system is detecting, or the nervous system in general has receptors that detect pressures in the carotid arteries, and it's going to respond. If pressure drops, it responds, constricts those arteries, and increases blood flow to the brain so you're not dizzy. So that's a quicker response, the nervous system acting through axons and action potentials, right? But the endocrine system is a slower, more gradual response, and then the effects of it take a little longer to go away as well. For example, if I eat a sandwich, do I want a surge of insulin very quickly into my blood and then dropping blood sugar really fast? No, I want a little bit of insulin secretion, and then slowly that insulin will be broken down and metabolized until we eat again. So Endocrine system is slower, lasts longer, but works with the nervous system to maintain homeostasis. So an endocrinologist is someone who's going to study people with hormone disorders. So an endocrinologist, like reproductive endocrinology, would be someone who is a couple that maybe is struggling with infertility. They're going to see a reproductive endocrinologist to look at hormone levels and how the reproductive system is responding and looking for ways to promote fertility. So like I said, what defines endocrine glands is that they produce hormones to the blood. There are no ducts for these hormones to pass through. It's secreted directly to the blood. So there's capillaries infused in these endocrine glands that receive the hormones produced by the endocrine glands, and then they're carried off and whisked away in the blood. So when you eat a sandwich and your pancreas secretes insulin, the capillaries in the pancreas take up that insulin that is produced by the pancreas and distributes that insulin throughout the body. That's why we can poke a patient anywhere, right, and get a blood sugar level. And then we can also, the effects of insulin will be in that blood sugar level system-wide. So if I give them too much insulin, it's going to drop blood sugar, and I can test that anywhere in the body because insulin goes everywhere. Every receptor has, or every cell has receptors for insulin. But exocrine glands, like I said, are not part of the endocrine system, and we can have effects of secretions of organs that go through ducts locally. For example, well, you tell me some. It gives you two examples: sweat glands, sudoriferous ducts. Where are those located? In our skin. They produce sweat, and that sweat travels not to the blood. The sweat travels where? Where? Yeah, to the skin surface for cooling. So it maintains homeostasis, but it's not an endocrine gland. It's not an endocrine hormone because it goes to a duct. And saliva travels through the salivary duct. So we have that big parotid salivary gland, right in front of your ear. That travels via salivary ducts to the mouth, where it helps with digestion of starch, right, and has antimicrobial properties and all those other features of saliva. So other examples of exocrine glands, so these are good test questions: which of the following is not an endocrine gland, or which of the following is an endocrine gland? Other examples of exocrine glands would be lactiferous ducts. What is that? Where is that found? No? Yeah, in the breast, going to the nipple to feed the newborn, right? So that's carrying milk, not related to the endocrine system because it's traveling through a duct, not through the blood. And it's very localized and very specific. Lacrimal, Jen, in the eye, right? And that serves to lubricate the eye. So the lacrimal gland, remember, is located above the eye and travels to the lacrimal gland, travels to the eye, and then the lacrimal gland drains the lacrimal duct drains the eye and leads to the nasal cavity. That's why you get a watery nose if you've been crying or having a teary eyes. Pancreatic duct, hepatic duct, cystic duct, common bile duct. All of those things lead to not to the blood, duodenum of the small intestine for digestion and absorption, right? So those are examples of exocrine glands. Exocrine is outside the blood. So endo, inside the blood, is where we find the hormones. Exocrine, outside the blood, in ducts, very localized actions. It's not going to the blood. So endocrine glands lack ducts. There's just going to be a nice nourishing capillary bed there to pick up those hormones and take them where they need to go. So when you look at the endocrine glands, the pituitary, thyroid, parathyroid, adrenal, and pineal, those are true endocrine glands. They secrete hormones to the blood. They don't have any ducts associated with them. The hypothalamus, we already said, is a neuroendocrine organ because it's in charge of the nervous system, autonomic nervous system, as well as the endocrine system. And then the pancreas, the gonads. What are the gonads? Yes, the ovaries and testes are the gonads. So they are endocrine and exocrine, which means they produce some things locally and also to the blood. The placenta as well secretes chemicals locally as well as to the blood. And then other tissues and organs that aren't really endocrine organs, but they do secrete a hormone. So they do secrete something to the blood, but they have other functions as well. Adipose cells, and I want you to list these. So adipose cells, there's a number of different hormones, but the one I want you to know is leptin, Leptin, leptin. And that is a hormone that keeps us from feeling hungry. So that's the anti-hunger hormone. We'll talk more about that in a little bit. The thymus secretes thymosin, and thymosin helps regulate our immune system and the maturation of T cells. The walls of the small intestine secrete hormones to support digestion, and there's a number of those. Let's see, we'll choose secretin, S-E-C-R-E-T-I-N. Secretin is an important small intestine hormone. There's others we'll study in the digestive system, but for now we'll just mention one. The stomach is gastrin. Gastrin is an important hormone the stomach releases. The kidneys, do you remember which hormone the kidneys produce that helps us deal with low oxygen levels? And athletes sometimes abuse this. They used to until we tested for it. Yep, blood doping. Yep, EPO, erythropoietin. You don't have to spell that out. EPO. P is in Peter. EPO. And the heart secretes a hormone called A, N is in Nancy, P is in Paul, ANP, which stands for atrial natriuretic peptide. And that's one of the hormones that when we have high blood pressure, it causes us to decrease the reabsorption of sodium, so we urinate more. But we'll study more about that in the cardiovascular. I just want you to know one of each of these other organs that secrete hormones. So ANP is the name of the hormone, and it's from the walls of the atria that secrete that hormone. So we can study hormone structure a little bit in the sense that there's water-soluble hormones and there's fat-soluble hormones or lipid-soluble hormones. And because in advanced A&P, we're not going to go through every one of these endocrine organs and you're going to have to memorize what they all produce. No, we're not going to do that. We're going to talk more about how the endocrine system works as a whole and the role of the hypothalamus and the pituitary gland. Because that's, you can always look up a hormone in a list and know what it does on a cell. But I want you to see kind of big picture stuff. And I'll give you some examples of that in the healthcare field as we get going here. So amino acid-based hormones, those are water-soluble, which means can they diffuse through a phospholipid bilayer of our cells? If it's water-soluble, do water and oil mix well together? Nope. So therefore, these need a receptor that's going to allow them to transport through that membrane with a helper, like a protein carrier, okay, or a protein channel. Steroids, those are fatty molecules. Do you remember what the base structure of all steroids are? If I look at its chemical structure, where it comes from, what's the major fat in our blood that people get tested all the time? Cholesterol, yeah. Cholesterol is a 4-ring structure that forms the base of all of our steroid hormones. So any hormone that is a steroid is fatty, comes from cholesterol. That's right there in your notes. And the gonadal and adrenocortical hormones. So let's list those. What are the gonadal hormones? What are the hormones secreted by the ovaries and testes? There's 3. Testosterone from the testes and estrogen and progesterone. So those are the 3 hormones. And we also know that fat cells produce estrogen as well. So that's why people that are obese have higher risk for breast cancers, because some Breast cancers are estrogen-based. The more estrogen, the higher the risk for cancer to develop. And that's also why women who are overweight have more trouble with fertility because of higher estrogen levels. And men produce estrogen in their fat cells as well. So those are all steroid hormones that have a different way of entering the cell or activating the cell, because they can diffuse right in. And if they diffuse right in, that isn't necessarily good, right? Because everything goes from high to low concentration. So if it diffuses in, we can't have this big buildup of hormone inside the cell. So there's another player. There's a receptor for those hormones, but the receptor is inside the cell. And we'll talk about that when we get to those specific hormones. So most of the hormones in our body are amino acid based. So they require receptors on the outside of the cell. They cannot diffuse in. And the other ones, like I said, that are from the gonads, testes and ovaries, we recognize those. The adrenocortical hormones, what organ, what's the root word in adrenocortical? What organ are we looking at? Adrenal cortex. Adrenal cortex. And where is the adrenal cortex? It's on the kidney. So if we go back to this picture here, adrenal cortex. Well, the adrenal gland is this whole gland sitting on top of the kidney. The cortex, is that on the inside of that triangular organ or on the outside of the organ? Think of the cortex when you study that in general A&P, like in the kidney. Is the cortex on the inside of the kidney or the outer edge of the kidney? I always told my students medulla is inside, middle, medulla middle. Cortex is like cork, like on the outside, okay? So the adrenal cortex is the outer layer of the adrenal gland. So there's cells that produce different hormones compared to the adrenal medulla, which is on the middle portion of this triangular gland. And the only hormone on the inside, the adrenal medulla, that is secreted is epinephrine. That's part of the sympathetic nervous system, right? So the outer edge of the adrenal gland are the adrenocorticotropic hormones, and those are, not tropic, adrenocortical hormones. And those two are aldosterone. So back to the slide. Aldosterone, so the two examples here, aldosterone and cortisol. In general A&P, we call aldosterone, we call that a mineral corticoid because it influences the movement of sodium. And cortisol, we call the glucocorticoid because it influences blood sugar levels. So cortisol and aldosterone. Now cortisol, we know we use a derivative of cortisol, which is called cortisone, right? Which we call, what do we call that? In the medical, anybody ever take cortisone? Solumedrol, what? Yeah, cortisone shots. What do cortisone shots do? Yep, it decreases inflammation in the joint. Yeah, so people who get cortisone shots typically have some type of damage and inflammation in an area, and the cortisone decreases that. And we also have people inhale it. We have steroid inhalers that people use to decrease inflammation in their airways to help them breathe better. So it's a really popular thing for people to take to decrease inflammation, but it also mimics the effects of cortisol, which is a stress hormone. And the effects of stress on the body are decreased immune function, water and weight gain, and it tends to promote a feeling of anxiety. Prednisone, have you heard of prednisone? So that's a chemical version of cortisone, these glucocorticoids. So people tend to have weight gain, anxiety, insomnia, but decreased inflammation, so that's good, right? If you can't breathe, what is the choice? Breathe better and get your oxygen saturations up, or suffer the side effects. The doctors are going to choose, let's get your breathing better, right? And people want to breathe better. They'll deal with the side effects. But we don't like to keep people on steroids for long periods of time because it's hard on the body. It's like long-term stress. We know it's hard on the body. So we have to give them the steroids, get them feeling better, and then taper off those steroids. So when a patient comes in and you see they're on, been on steroids for 3 days and they have high blood sugars all of a sudden, it's like, oh my gosh, why is her blood sugar through the roof? This person who's a type 2 diabetic, why does she have these really high blood sugars all of a sudden? You'll say, yeah, I know why, because she's on this steroid, she's on the prednisone, which acts like cortisol, which raises blood sugars. That's the response of that hormone on the body. And why can't she sleep at night and she's up all night on the call light? Because she's on cortisone, and that acts like a stressor to the body, and that causes insomnia. So again, kind of knowing your physiology, you're going to be able to explain to your patient what's going on and say, yep, these are the side effects, but this is the benefit of this medicine, and that's that you can breathe better. Okay, so when you look at the actions of hormones, we can secrete estrogen, but it's not going to have any effect if we don't have receptors for estrogen in the body. Or if a person, for example, is a type 2 diabetic, what we find is when people are with higher obesity in the US, we have found that obesity is linked to desensitization of cells to insulin. So you have normal pancreatic function, they're secreting insulin, but for some reason the cells, when insulin binds to those cells, it's not allowing glucose to enter like it should. The cells are not responding like they should to allow glucose in when insulin binds. So what do we do as a result? We give people more insulin to kick those cells into gear to allow that sugar in and to lower those blood sugars. So cells have to have a receptor. So if a cell has a receptor for a specific hormone, we call it a target cell. So a hormone is secreted, and the target is the cell that has a receptor waiting for that hormone. For example, we know that all the cells in the body need glucose, so therefore they have receptors for insulin. They're all target cells. But if you look at your list that I gave you, for example, let's find a simple one, if there is such a thing. Well, those are... Okay, if I look at the hypothalamus, for example, we're going to talk about that. The target cells for the hypothalamic hormones are on the anterior pituitary, because the anterior pituitary is like the secretary of the boss, the hypothalamus, telling the rest of the endocrine system what to do. So if I look at, for example, thyroid releasing hormone, TRH, is produced by the hypothalamus. That will travel through a special blood capillary network to the anterior pituitary, and the anterior pituitary gland has a receptor for TRH, which tells the anterior pituitary to secrete TSH. So TRH anywhere else in the body does not cause an effect, because there's no receptor for it other than on the anterior pituitary. So whenever we have a target cell with a receptor, when a hormone binds it, that target cell can do a couple of different things. It can change the permeability by opening or closing ion channels. For example, in the kidneys, when aldosterone binds to cells of the kidney in the nephron, aldosterone causes increased reabsorption of sodium. So it's going to turn on ion channels in the nephron to grab sodium and put it back into the blood. Stimulating the synthesis of enzymes or other proteins, testosterone causes growth. It causes growth in muscle. So we know the anabolic steroids are what bodybuilders will sometimes use. That's going to cause synthesis of enzymes and proteins related to increased muscle growth. Deactivating or activating enzymes. So depending in the digestive tract, when we're promoting digestion and production of enzymes, some of those hormones we talked about, gastrin and secretin, cholecystokinin, some of those digestive hormones stimulate or deactivate enzyme production for digestion. Inducing secretory activity. We know that prolactin, when it acts on the alveolar glands of the breast causes secretion and production of milk, right? So those are target cells for different hormones. And then stimulating mitosis, growth hormone, when it binds to cells throughout the body during puberty, childhood, infancy, promotes mitosis and production of cells to grow the human body. So those are all examples of actions of hormones on different target cells. So again, it depends though, when that hormone binds to that target cell, whether that hormone is going to bind to a surface receptor or if it's going to enter the cell and activate a gene. And where are genes located? Chromosomes have genes, yep. And where in the cell would I find them? In the nucleus, because genes are on DNA in the nucleus. So we'll look at a diagram of these processes. So when we're looking at a steroid hormone, so you see this fatty hormone, so this could be aldosterone, cortisol, testosterone, estrogen, progesterone, right? Any one of those can diffuse right into the plasma membrane, but it binds to a receptor in the cytoplasm. So there's a receptor for that hormone if it's a target cell, right? It's going to bind to that receptor inside, and then that can enter the nucleus. Once it's bound to the receptor hormone, it comes into the nucleus and then binds to that DNA and causes protein synthesis. So now you have whatever that target cell is producing, it's producing a new protein. But it's not going to happen until it binds to a receptor inside and starts protein synthesis. So if we look at that process versus the other type, which we'll look at in a minute, well, let's just compare the two. So this is a steroid-based. So what would a amino acid-based stimulation look like? Where is the receptor? In the membrane on the surface, right? So when it binds to the surface, it's not stimulating protein synthesis because you have to turn on DNA to do that, right? So it's not entering the nucleus. So what happens is these cells have already produced their product and they're just waiting to be stimulated. So whatever that cell needs to do is already completed. It just needs a receptor to bind to the hormone to turn it on and say, okay, you can release that now. So if you think about it, it's kind of like this example here is like a sit-down restaurant. If you're hungry, what do? You come inside the cell, you sit at your table, which is the receptor protein, and then the waiter comes out and takes your order, goes into the nucleus, and makes your dinner, right? And then it comes back out, and you have your dinner, which is the new protein. That takes time, right? So when we look at steroid-based hormones and the target cell response, it takes longer because we got to make the protein after the binding occurs. You got to enter the restaurant, order your meal, and make the meal. What would an amino acid-based protein response be like? A fast food, yeah. You do enter the restaurant when you go through the drive-through of McDonald's? No, right? And what do? You give them the money, so you bind the target cell, and then they exocytosis, right? Your bag of burgers in the bag. There's your response from that target cell. Pretty quick, right? Because it's already produced. All they got to do is package it and take it out. So what can we say about amino acid-based hormone response? Faster, because it doesn't require gene activation. Okay, so how well we get a response depends on some other things. It depends on how much hormone is in the blood. So if I have low hormone secretion, if I have low insulin secretion and low levels of insulin in the blood, am I going to get good control of blood sugar? No, so I got to give more insulin, right? That's why people have to supplement with insulin. Even if they have pancreatic production of insulin, like a type 2 diabetic does, they need more insulin to kick those cells into gear. But now a person with type 1 diabetes, they have no insulin production, so they have to completely rely on injecting insulin either through a pump or through needles. They have to have complete replacement, not like a type 1 diabetic that has a little bit of response because they have a normal pancreas. So the way we can stimulate an endocrine gland to respond to some disturbance in the body, there's 3 different ways. So we're talking about endocrine glands here now. We're not talking about target cells. So endocrine glands are secreted to produce their hormone to the blood in 3 major categories. There's a humoral stimulus, which means there's something in the blood that's off, and we need to fix it. So for example, letter A there, the first diagram, is pointing to the 4 little circles on the thyroid gland. So this whole thing is the thyroid gland, but the 4 little circles here are the parathyroid gland. So the parathyroid gland, you remember from general A&P, we called it parathyroid hormone, which is what's secreted by the parathyroid gland. We called parathyroid hormone the bone breaker, and that's because it stimulates osteoclasts in our bones to release what important ion? Calcium. So what stimulates the parathyroid gland to secrete parathyroid hormone is the levels of calcium in the blood. So therefore, we call that a humoral stimulus, which means some chemical in the blood is stimulating that gland to do its job. So that's an example of humoral stimulus. So you could even, add at the bottom of these arrows, calcium ion is what is being released there. And what stimulated it? You could write it above here, low calcium in the blood, right? So calcium ion would be released then by parathyroid hormone. So that's an example of a humoral stimulus. Another one is a neural stimulus. So here we see a neuron sending an action potential to stimulate the middle of this gland. What is this gland called? What is that triangular gland we talked about? Yeah, the adrenal gland. And the middle portion is what's being stimulated by that neuron, and that's the adrenal medulla. So what is it secreting to the blood here? What hormone? And I want you to write it in. What's the hormone that comes, the one hormone that comes from the adrenal medulla? What? Epinephrine. Yep, epinephrine. So that's the stress response. And the only way to get epinephrine released is we have to stimulate the neuron of the sympathetic nervous system. So that yellow axon there, neuron, is part of the sympathetic response. And that's for short-term stress, right? Like if all of a sudden you heard, a gunshot in the hallway, your heart rate would go up, right? Blood pressure would go up because of the sudden release of epinephrine to the blood. And is that a quick response? What type of hormone do you think epinephrine is? Amino acid based or steroid based? Fast food restaurant or sit down? Amino acid based, so acting like a fast food restaurant. That epinephrine is ready to go, ready to be released into the blood. So we get a quick response, which is good because we want that fight or flight response to keep us safe. Okay, so that's an example of a neural stimulus. It's the only neural stimulus that we deal with on a regular basis. And then the next one, this is the most common, is a hormonal stimulus, which means a hormone is being released to the blood by the anterior pituitary or the hypothalamus, which is causing that endocrine gland to respond. So these glands are kind of slaves to other glands. So for example, if I look at this last picture here, that blue vessel is part of the special blood supply between the hypothalamus and the anterior pituitary, and it's stimulating the anterior pituitary to release something to cause the thyroid gland to secrete its hormone. What is the hormone from the anterior pituitary? We could write in right here. What hormone is being released by the anterior pituitary that stimulates the thyroid gland? TSH. Yep, so we'd write TSH right here. And then the 2 hormones, or the one primary hormone from the thyroid gland is T3 and T4, right? So T3 and T4 are what the thyroid gland will produce when it's stimulated by a hormone, TSH. So TSH goes above the thyroid gland, and then what the thyroid gland secretes is T3 and T4. So this is pointing to the adrenal gland. So there's one hormone that stimulates the adrenal cortex that comes from the anterior pituitary. Do you remember what that's, the abbreviation for that is? ACTH. Yep, Adrenal Corticotropic Hormone. So ACTH you would write here. And when that binds to receptors on the adrenal cortex, which we said is the outer portion, that stimulates the adrenal cortex to produce, what are the two hormones we said are the adrenal cortical hormones? Cortisol and, what was the other one with sodium? Aldosterone, cortisol and aldosterone. And this is stimulating the testes. So what hormone stimulates the testes to produce another hormone? Well, let's look at the one above it first. What anterior pituitary hormone stimulates LH. So LH here from the anterior pituitary is a humoral stimulus for the testes to produce what hormone? Testosterone. You could just put testosterone. Androgens are male-like hormones. Yeah. So you can, that's a more generic term. We're just using testosterone because people are more familiar with that. So these are the stimuli, right? These three hormones we listed here. So we have TSH, ACTH, and LH. Those are the stimuli, the hormonal stimuli for these endocrine glands to secrete their hormones. And we said it was T3 and T4, cortisol and aldosterone, and testosterone. So be able to distinguish among the three different stimuli for an endocrine gland to do its job. So again, we talked about that they have to have receptors. Other things that are going to stimulate that target cell is blood levels. We already talked about that. The more insulin, the more I'm going to have blood sugar leaving the blood and entering cells. The number of receptors. So if I have a lot of receptors for a hormone, it's going to cause more of a stimulus for that target cell. And the strength of binding, how well that hormone binds to the receptor. That's a chemical reaction based on the chemical structure of the hormone and the chemical structure of the receptor. So the stronger they bind, the longer and more intense response I'm going to get from that target cell. So then we run into this little issue in the human condition of upregulation and downregulation. And I have a lot of nice examples of that to help us understand our patients a little better. Upregulation is when we have low response to we have low hormone levels. In some cases, the body will respond by adding more receptors for that hormone. And an example of that is in pregnancy. There's lower estrogen levels in pregnancy as a result of, the lack of menstrual cycles during pregnancy. So estrogen levels are a little lower. So as a result, there's fewer hormone of estrogen. So the uterus responds by upregulating receptors for estrogen. Then, as estrogen levels go up near the end of pregnancy, and this is a whole nother topic, we're not going to explain why or how that happens, just take that at face value for right now. But as estrogen levels increase at the end of pregnancy, we have all these larger receptor sites now on the uterus, and the response of estrogen on the uterus is to contract. So people start to get these false labor contractions called Braxton-Hicks contractions at the end of pregnancy because of upregulation of receptors for estrogen. So they start to get these contractions. And the benefit of Braxton-Hicks contractions, if a person has them, is it's little practice squeezes of the uterus, and it's actually good for the baby to get those practice squeezes because it stimulates, do you remember the important chemical produced in the lungs that fights surface tension? Do you remember what that is? Starts with a S? Very good, surfactant. So Braxton-Hicks contractions actually promote surfactant production in those later term babies and helps them breathe better when they're born. So it's not a bad thing, but it can be really uncomfortable for some women that have a very sensitive uterus that has a lot of those Braxton-Hicks contractions. Down regulation is the real problematic one. This is what we see when people abuse heroin and opioid pain medicines. What happens is when we respond to have all these opioids in the blood, the opioid receptors, because there's such high levels, they downregulate. And as they downregulate, if there's fewer receptors, then the cells are less responsive to the binding of those opioids. So what happens when a person takes one hit of heroin after they've done that for a period of time and downregulation has set in? Are they going to get the same high on the one hit? No, they're going to go for more, right? And then it starts that cycle. And then they say, you know, why are people dying in lacrosse? People that work in the ER, the number of overdose situations coming into the ER is really high here in lacrosse, even compared to some big cities. We've got a big problem here in lacrosse. You work in that environment, right? Do you see a lot of those?
I know from my
Okay. Yeah, I had a cousin who was a paramedic firefighter, and he said, he lives in Waukesha now, he said the number of overdoses, heroin overdoses here was like 5 times higher than what he sees in Waukesha, just because, you know, the drug dealers get more money for heroin here because we're kind of far from Milwaukee and Minneapolis, so it's harder to get drugs if you want it, so people will pay more to find drugs locally here rather than travel where it's everywhere in Milwaukee and Minneapolis, so that price, you know, it's supply and demand kind of thing. So anyway, same thing with your pain med. So when people, you know, get prescribed oxycodone or Lortab, or what are the ones out there? Those are the ones that just come to the top of my mind. That's what we're giving a lot of. Hydromorphone is another one. People get prescribed that for pain. They find it doesn't relieve their pain after a while, and they have to add something new on. And then they get less of a response. And that's where the addiction comes in then. They're not getting the response from those pain meds anymore because of downregulation. Another thing happens with chronic marijuana usage. Marijuana helps people feel mellow, right? That's why people like that drug, and that's why it's being legalized, because a lot of people are using it, and it's supporting the drug trade and all the issues related to that. But one fact is true is that it does give a mellowing effect. The THC is the part that contributes to that. A lot of that is that it helps control anxiety. But then the natural hormone release and receptors for our normal anxiety releasing neurotransmitters are down-regulated because there's so much of this marijuana in the system. And I'm talking about chronic marijuana use. I'm not talking about occasional recreational use, like going to a party and smoking marijuana. I'm talking about people that get up in the morning, smoke marijuana all day long until they go to bed. Those type of situations, there's downregulation that occurs, so therefore when they stop using the marijuana, the brain is no longer able to deal with anxiety because there's been so much THC in the system that they've down-regulated those receptors for anxiety control. And people find when they stop using marijuana after chronic usage that they have trouble with anxiety and insomnia. So then as a result, they use it for anxiety and insomnia, right? But it's like the chicken or the egg, which came first, right? So that's where we have to really be careful with the research that's out there that yes, it controls anxiety, but is it a result of that it also caused anxiety and which made people become dependent? No, we know that it's not physically dependent like alcohol, that if you stop using it, you go into seizures and you can have cardiac arrest. So we know that the physical dependence in that sense isn't there. But the down-regulation is definitely a factor, and we see that with a lot of drugs that alter brain activity. is downregulation is a factor which desensitizes our cells. Another big one to understand patients, bariatric patients, you know what bariatric means? Overweight, obese, it's the clinical term for that, right? It's a respectful term for obesity. Bariatric patients, people that struggle with lifelong, obesity. We know that leptin, I already told you, is a hormone produced by fat cells that suppresses the appetite. Well, what happens if we have lots of adipose cells? What happens to leptin levels if you have? It increases. So if you have a lot of leptin in the blood, the hypothalamus has receptors for leptin to tell the hypothalamus we're not hungry anymore, we don't need to eat. But what happens to the hypothalamus if we have chronically high leptin levels? Yeah, desensitized. So then how do people feel if they don't have normal leptin secretion and response? Hungry. So that's the struggle. It's the vicious cycle that people get in with obesity, is the more fat cells, the more leptin, the less response, and then they feel hungry all the time. So weight loss is a real struggle for people that have a lot of adipose tissue. So that's why it's important to eat, right? So when people are dieting, like we see people, bariatric patients that are 400, 500, 600 pounds, and they're not eating because they're embarrassed of their size, and they don't want to eat because they don't want to show everybody, that what led them to this situation. But you have to tell them, you need to eat because you're sick and you're used to getting a lot of calories. You don't come in now and set in a starvation mode. That's not the way to lose weight, because when obese patients lose weight rapidly, it dumps so much cholesterol in the blood that it raises cholesterol levels and can lead to heart attack and stroke. So we really have to be careful with gradual weight loss and doing it in a healthy way and encouraging those patients to eat and not being judgmental. Okay, so looking at how long hormones last in the body. We already said steroid hormones and thyroid hormone is kind of an exception to the rule, acts like a lipid-based hormone. Those are attached to plasma proteins and they're transported throughout the blood. Amino acid base, they're free-floating in the plasma of our blood, so they do not have carriers. So that affects how they're recycled or broken down and metabolized. So when you look at hormones, kidneys or livers are the two major organs that metabolize and break down our hormones. The kidneys are responsible for, if you remember, the kidneys are important for protein metabolism, transamination, oxidative deamination. So that's the organ for metabolizing protein-based hormones, is the kidneys. And then the liver is responsible for breaking down those steroid-based hormones, testosterone, estrogen, all those. And we talked about the response time of amino acid-based hormones is faster. And here's a nice little chart that, to summarize, so you could just kind of compare the two sides of the amino acid based, are the water soluble, and the lipid soluble are those steroids. So you can just kind of look and see, are they stored in secretory vesicles? No, this is the sit-down restaurant, right? That's where you have to activate a gene and it's made on site, where these are stored in vesicles like a bag of burgers from the McDonald's drive-thru. These are transported, bound to plasma proteins. These are free in the plasma. And where do plasma proteins come from? What organ is in charge of making plasma proteins? Do you know? Organ. Well, yeah, organelle too. We know proteins are made by the rough ER with the ribosomes and the Golgi apparatus for packaging. But in terms of organs, most of our plasma proteins are made in the liver. So people with liver disease, what are their hormone levels going to be like of these steroid-based hormones? They're going to be affected, right? They're going to have poor transport. Yep. So half-life, these hang out longer in the blood. These are short-lived. Where are the receptors? These are inside the cell, right? These are on the surface. And how do they stimulate or get those target cells to kick in gear? They activate genes in the nucleus. And this is through a second messenger system that's activated once it binds to the surface receptor. But we're not going to go into the details of the different second messenger systems. That's beyond the scope of our class. So we'll pick up next time talking about the role of the hypothalamus and the anterior and posterior pituitary.